Chapter 21 covers nursing care of the family during the postpartum period. Here are your learning objectives. So, nursing care of the postpartum woman. The nurse provides family-centered care that focuses on assessment and support of a woman's psychologic, physiologic, and emotional adaptations after birth. Care is wellness-oriented. So in the United States, we tend to treat labor and delivery and pregnancy like it's a medical condition, but really it's just a normal process of life, and we need to treat it more like wellness instead of a sickness. The typical hospital stay is 1 to 2 days after a vaginal delivery. Care must be carefully planned and provided because we have a very short amount of time to share a lot of information. So basically after delivery, you're starting to teach towards discharge home of normal postpartum care, normal newborn care, how to take care, a mom, how to take care of themselves, and how to take care of their new infant. This picture shows a fundal massage. So here you see the nurse palpating the fundus of the uterus during the normal postpartum period. If you note, the upper hand is cupped over the fundus, and the lower hand dips in above the symphysis pubis and supports the uterus while it's gently massaged. So the reason you want to support the lower part of the uterus is not to cause a uterine prolapse. That's very rare. I've never seen a uterine prolapse from fundal massage in my entire career, but it can happen. So as far as transfer from the recovery area, the post-anesthesia recovery, regardless of the obstetric status, no patient should be discharged from the recovery area until they're completely recovered from anesthesia. Patients who receive general or regional anesthesia should be cleared by a member of the anesthesia team. This isn't always a requirement in some hospitals. For instance, the hospitals I have worked at, after a vaginal delivery, a normal vaginal delivery, as the nurse, I would assess my patient, I would take out the epidural catheter and assess the site, and when she reached a certain ability to, move her legs and recovered, we could transfer our patients to postpartum. When you do transfer them from the recovery area, it's important, as much as possible, you'll see a shift now in how a report is given, but a bedside shift report is the best kind of report you can give, where you transfer your patient to their next area and you give report to the nurse receiving the patient at the bedside and involve the patient and her family in that report and their care. It's safer for patients and also increases patient satisfaction. In labor and delivery, recovery, and postpartum settings, that's referred to as LDRP. So that's a room where they labor, deliver, recover, and have their postpartum stay in their entire hospital stay from admission to discharge within the same room, and usually cared by the same nurse. The nurse provides the same level of care without moving the client. When you give report on your patient, there's two reports that you'll give. You'll give report on mom and report on baby, and these reports are, pretty long and extensive. So as far as maternal, you'll give her name, her age, the name of her provider, what her gravida impera is, the type of anesthetic she was given, any meds she received in labor, the duration of her labor, the time her membranes ruptured, whether her labor was induced or augmented, the type of birth, and perineal repair, her blood type and RH, what her GBS status was, her rubella status, the status of her HIV, Hep B, and syphilis, if she had any other infections, the type and amount of IV fluids, the location of her fundus, the type of lochia and how much, if her bladder is distended, or if she's been able to void or had to have a catheter, the sex and weight of the infant, the time of birth, the name of the pediatrician, and if she's chosen to breast or bottle feed, and the interaction that she's had with the baby. The report that you would give on the baby, so if you're in a hospital where you provide couplet care, you're giving report on the mom and the baby to one nurse. If you're not doing couplet care, you're going to give a separate report to the baby nurse. You're going to give APGAR scores, the baby's weight, if the baby has voided or stooled since delivery, if they've been fed since birth, their eye prophylaxis and vitamin K administration, footprints, armbands, and then any pertinent labor and birth information. And here's where we talked about from the initial contact with the postpartum patient, nurses prepare the mother for her return home. The length of stay is dependent on many factors: the condition of the mom and baby, emotional and mental status of the mother, what kind of social support they have at home, what their needs are for education, and if they have any financial constraints. For instance, if it's somebody that's had their first baby, they're a single mom, they don't have a lot of support at home, that may not be a good patient to discharge early. They may stay their maximum amount of time. If you have a mom who's had her third baby and she has support at home, it is a lot easier to discharge them early. This picture shows how to monitor bleeding after delivery, and this is a pad. So this has blood loss after birth, is assessed by the extent of saturation on the perineal pad. So the first picture is scant. You have less than 2.5 centimeters of blood. The second is light, and you have less than 10 centimeters. The third is moderate, greater than 10 centimeters. And the last is a heavy pad, which is saturated within 2 hours. So it's important to know how long the patient has had their pad on. If you have a pad like this last one that's heavy, saturated, if they've had it on for 8 hours, that's different than if they've only had it on for 30 minutes and they've saturated that pad. So you always want to not only assess the blood on their pad, but always ask the patient how long they've been wearing that pad. There are laws related to discharge. In 1996, there was the Newborns and Mothers Health Protection Act. And this had advantages and disadvantages to early postpartum discharge. So basically in 1996, there was a law that was passed that you cannot discharge moms early. So with this Newborn and Mothers Health Protection Act of 1996, that you cannot discharge a mom who's delivered vaginally. They get a minimum of 48 hours, and a C-section gets a minimum of 96 hours. That health plans are required to pay for that length of discharge, that length of hospital stay. So, if a patient and her provider decides she wants to go home early, that is okay, but this act requires their insurance to pay up to a minimum of 48 hours for uncomplicated vaginal birth and 96 hours for a C-section. Nurses wear multiple hats. They play the role of caregiver, teacher, and advocate. Criteria for early discharge are that the mother is recovered and that she's able to take care of herself and her baby. Those that are at risk for complications, those that are at low risk for complications can be discharged as early as 6 hours from a birth center and 24 to 36 hours from a hospital. So a birth center, if mom and baby are doing great and she's comfortable going home, they can be discharged as early as 6 hours after delivery. Ongoing maternal physical assessment include vital signs, breast, uterine fundus, lochia, the condition of their perineum, bladder and bowel function, and their leg function. So that could be as a result of epidural anesthesia and then DVT prophylaxis also. Table 21-1 on page 486 has postpartum assessment and signs of potential complications. So again, this is where you have to know what normal is to be able to decipher what's abnormal. Postpartum care management, we're going to go through each of these. Routine lab tests include H&H and possible a UA if the patient received a Foley catheter, so you can determine if they got a catheter-associated UTI. Prevention of excess bleeding. The most frequent cause of excess bleeding is from uterine atony, which is secondary to retained placental fragments. So I'll say that again. The most frequent cause of excess bleeding is from uterine atony, so the uterus is not firm like it should be, due to retained placental fragments. Hematomas or unrepaired lacerations can cause bleeding. So if you have a uterus that's firm, a fundus that's firm, and there's still active bleeding, then it could possibly be from an internal hematoma in the vaginal canal. So they could actually be actively bleeding internally, but there's no blood coming out. Or there could be an unrepaired laceration of the cervix or vaginal canal that you see vaginal bleeding. You want to monitor their H&H. Another way is to weigh their pads, or not just their pads, but it could be the linen underneath them. If you know how much a dry pad or dry linen weighs, then you can weigh the saturated pad or linen. And 1 gram is equal to 1 ml of blood loss, so that's one way to figure that out. The signs and symptoms of hypovolemic shock are listed on page 487 in your book, but I just wanted to note that a decrease in blood pressure is a late sign of hypovolemia because of compensatory mechanisms. Next is uterine tone. You want to do fundal massage. You want to teach patients that it can be painful and they're going to be more tolerant of it if they expect it to be slightly painful. If the uterus is not firm, you can give IV fluids, and they'll usually also contain some kind of oxytocin or Pitocin or Methergin. You can give different types of meds to cause the uterus to contract. Some are right in the IV and some you would administer IM. Bladder distension, so we want to prevent that. We know that a distended bladder prevents the uterus from contracting, which can cause bleeding. If mom is having difficulty voiding, you could have her listen to running water, put her hands in warm water, squeeze warm water over her perineum in her little bottle that she has. She can take a warm bath or a sitz bath and void while she's sitting in it. And if she's in pain, you also want to give her pain medicines to help with that. If after you've done all that and they still cannot void, they may have to have a Foley catheter. For prevention of infection, OB nurses are what I call germaphobes. They are just excellent at washing their hands and preventing infections, even to the point that compared to med-surg nurses, OB nurses do not come to work if they're sick. They don't come to work if they have fever blisters, because they don't want to risk the chance of infecting moms and babies. That's the difference between OB and like med-surg, is that OB patients and newborns are healthy and they're very susceptible to infection just being in the hospital itself. So as an OB nurse, you don't want to bring a sickness to work to infect a normal healthy mom or baby. Whereas when you work on med-surg and you're kind of surrounded by germs, it's possible that you got that germ from a patient, and you might work with that same germ if you're going to care for those same patients the next day. But if you're sick, don't come to work, don't go to clinicals. Things that you can teach parents is hand washing. They need to instruct anybody who comes in the room and touches the baby or holds the baby to wash their hands, and also just very basic hygiene of teaching the mom to wipe from back to front, from front to back. So teaching the mom to wipe from front to back.